Epic, the EMR system, and we're also expecting that it will be an Epic Q&A session. In large part, that's because we have two great panelists that I'd like to introduce to you as we get started. Dr. Amy Miller is now the Chief Health Information Officer at Beth Israel Lahey Health, and David Rubins is the Medical Director of Advanced Decision Support. And we're going to be hearing from them in just a minute. As you look at the chat function, we really want to encourage you to be asking questions. It is a Q&A session. And so you can see how to do that on the screen. Make sure that your responses or chat comments are directed to everyone. That way the panelists will see them and the other people that are listening in along with you will see them as well. We really want people to see questions. And if you have answers to questions or responses to questions, you can respond to questions in the chat with messages of your own. So we want it to be as interactive as possible. We want it to be as responsive to your needs and interests. And as you registered, a number of you entered questions in the chat or in the registration process that you wanted to get answered today. And we will answer as many of those questions as we can, along with the question, any new questions that you put into the chat throughout the event. We do want to note that, you know, we do, as part of the Take Heart curriculum, have two whole modules devoted to implementing automatic referral, modules 5 and 7. And so if a question is a very basic one or a very general one, like, so how do I implement automatic referral? We really can't answer those questions with the depth that they deserve during this event. But we do want to point you to those modules. It's a set of slides. It's a recording of the slides. And we encourage you to review those if you haven't had a chance to do that already. So, as I said, our two panelists, presenters, question answerers, and fellow participants in the process of implementing automatic referral, Amy Miller and David Rubins, we're delighted to have them and are looking forward to their insights. But I thought we would just take a minute or two for each of them to just kind of provide a little bit of context for the introduction of automatic referral in their own systems. And so, Amy, if it's all right, let's just start with you. If you could just share why and how you implemented automatic referral in a general way, and perhaps if there's like a key message that you think is really important for everybody on today's call to understand, why don't you go ahead and share that as well?
Yeah, sure. So I'm actually a cardiologist by training, so this is an area that I am somewhat passionate about. My work on this was actually in my prior life. So I'm a recent transplant to BILH after spending about 20 years in the Mass General Brigham system. I was a cardiologist at the Brigham and worked on various EHRs within the Partners Healthcare, eventually Mass General Brigham system. So several years ago, the Mass General Brigham kind of cardiac rehabs broadly, we had multiple sites with cardiac rehabs, came to me in my role over informatics on our Epic instance to say, you know, we feel like we're not seeing enough referrals and we'd really like to prompt people to make sure that they think about it. I pulled in David, who is nothing short of brilliant in terms of finding ways to minimize the kind of friction that providers experience while delivering tools into the workflow that can kind of achieve the intended goal. We ended up being more successful and focusing more on inpatient as an area where we could really build these referrals into existing workflows and tools in a relatively painless way for the providers. And capture a population that one might argue has kind of a more pressing need than in the ambulatory setting. We did have some ambulatory tools to support referrals, but they were more frequently ignored, if you will. We didn't make them as kind of mandatorily addressed as the ones in the inpatient space. and tried to, streamline it as much as possible, again, so that the provider could be prompted to make the decision, but not feel like we were annoying them too much in the process. And I think overall we're pretty successful in doing that, again, thanks to David's brilliance.
All right, David, from your perspective, tell us how the process worked and as you work with Amy on this at Mass General Brigham.
Yeah, thanks, Amy. I don't think I have a ton to add to that. I just kind of reemphasize what Amy was saying about, I think, the most successful implementations that we have for lots of things, and for this in particular, is just having people defaulted to do the right thing. So the way that we have the discharge order set up is that it's easier to do the right thing than the wrong thing and not referring somebody. And that's been kind of shown multiple times, and I think really is like the key to the success of getting people to place these referral orders.
All right, thanks very much. Now, as I said, we had 60 or so substantive questions in the registration documents, and just to help us with the conversation today, we're going to start off with some general process questions and then talk about issues relating to diagnostic codes, embedding automatic referral into order sets, buy-in and training, and getting physicians to understand that it really is easy to do the right thing when you implement automatic referral. Follow up with some more process questions, and then we want to talk about reports. And then along the way, if you have additional questions, by all means, we'll try to address as many of them as we can as well. But this will just give you a sense that if you're really on here to listen to reports, we just don't want you to spend the first part of the call wondering whether or not we're ever going to get to that. Yes, we will get to these general topics. And if there's something that you don't see here, then by all means add that to the chat and we will address it as well. So there are a couple of general process questions that in various forms are asked by a number of you. And I should say that this is the second Q&A session that we've had for Epic. We've also had a couple of Q&A sessions for people that have a Cerner EMR, and one small session for people that use Meditech. And there are certainly differences between those EMRs, but I think that a lot of the ideas and the insights that you hear from Amy and David are going to be relevant to you even if you don't use an Epic EMR. There are some process things that are really important to do and to avoid doing, regardless of which specific EMR. And so we want to welcome everyone, regardless of what EMR you use. But just as a general question, a way to get us started, there are some people that are still interested in asking the question, so what's the first step in getting started? We're on the verge of this, but we just, how do we dive in? So Amy or David, from your perspectives, that key first step, what would you recommend are a first key step or two that people should be starting with?
So I think the first step is to make sure you have all the right people involved in the conversation, right? So you need to have the people who understand how you've built Epic, and then you need to have the people who understand how you're using Epic, how your users are interacting with it, which sometimes is different than the build team envisioned and imagines. And then, of course, the kind of the experts from cardiac rehab to speak to how they're going to handle referrals, how the referral process should work, as well as their expertise on kind of the diagnosis and billing code. So I think those are kind of the key players that you need to have involved, and you want to pull them together from the outset. The goal is really to figure out, in our world and the way our users interact with Epic, where is the kind of funnel where we can put this, that we think we can embed it in the process so that, as David said, it will be easier for them to do the right thing, right? We don't want to make them think about it at the wrong time. We don't want to put it someplace that half the users will never see it. So what is the place or places in the workflow where we can embed this that makes the most sense? And then kind of all of the logistical stuff on the back end about how do we make sure we're actually identifying the right patients and excluding the patients that this doesn't make sense for, et cetera. But all of that doesn't do you any good if you don't have it embedded in the right place in the workflow.
Yeah, thanks very much. And David, I hear people that ask the question, basically, we told our IT department or our whatever we called our relevant people, we told them that we needed them to build us an automatic referral system, and they said that they couldn't or they wouldn't. So from your perspective, what's the best way to get people started and working as a team on developing automatic referral?
So I think kind of there are a few parts to that. Uh, so I think, when people say we can't do something or we're not going to do something, ensuring that that is coming, trying to figure out where that's coming from. I think often one approach to that is just making sure that the right leadership is bought into the program and understands its importance, which often kind of trickles down to helping things move along from an IT perspective. I think another piece that sometimes comes up when Epic is asked to do something, or local Epic is asked to do something that we don't know how, or we don't really know where to start. I think the kind of either finding examples of people who already have done it, like us, for example, or going to the user web, which is one of Epic's forums, to kind of see what are other institutions doing, what seems to have worked well or not well for them. And even further, kind of on that user web, you can find pretty specific information about how other sites have built things. And I think using that as a starting point always helps kind of move things along. Like once you've done all of the things that Amy said, if you're really just getting down to the point where we need to figure out how to configure this in Epic, using that as a starting point can be really helpful.
Yeah, I think sometimes the words automatic anything throw people off. There's a concern that if you're asking to do something in an automated fashion in the EHR, that you're taking away decision making from physicians, and oh my God, should we do that? And Epic actually has some dyspepsia to the concept, honestly. So, I think one of the things to kind of probe on, as David said, is understanding what the resistance is. It may just be the misconception that you're saying, can we do this in a way that it just happens magically behind the scenes and we'll have a referral for everyone, as opposed to kind of the way it's intended, which is I'm going to prompt you, I'm going to make it so that it's very streamlined for you to make the referral, but you as the physician still always have the ability to say, no, 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 it's not right for this person. I'm not going to send them. And it doesn't happen in a kind of hidden or automated fashion without actual ability for clinical input.
Yeah, and let's follow up on that because there are, automatic referral can mean different things and can confuse people in some settings. So a variant of the question of is we identify the people, but the physician still has to check a box or something before anybody gets a referral. Is that really automatic referral, and how do we change that so that the referrals can be more fully automated than they currently are?
Yeah, and I think you have the ability, as you pull together that group, you can have the conversation about what you're comfortable with locally and what makes sense. You can absolutely default the selection. So you can put the check mark on the order so that it is going to happen unless someone unchecks it, right? And then the physician doesn't have to do anything other than let it happen if you've embedded it into an order set, for example, that they have to use anyway. Whether or not locally people are comfortable with that, I think is going to vary from site to site. And are you set up in a way that you know what to default, right? So we had multiple cardiac rehabs, and they each have their own referral. They go to different work queues, right? So if you're going to go to the Faulkner or you're going to go to Mass General, I actually need a different order. And so I could make assumptions based on the patient's address and say, oh, you live here, so I assume you want to go to Faulkner. We didn't want to make those kinds of assumptions. So we ended up saying we would rather have someone choose which one is the right one for this patient rather than default it. But it is totally technically possible to default the order to say, absolutely just make this kind of the path of least resistance. The patients will get a referral unless the doctor unchecks it.
Yeah, thanks. And that's a very good example. And I think that there are probably some programs and people listening in on this where basically they're only referring to a single hospital, and so it may not be as complex as it is in a large metropolitan area or a system where you have multiple potential referral sites. Another variant on the automatic referral question is we have order sets and automatic referral is built into some of them, but people don't necessarily use the right order sets. So how do we address the issue of, order sets and making sure that, everyone has the automatic referrals instead of just the patients where the physician picked the right order set?
Yeah, so I think it's a big question and extends beyond this as well, which is how, just the maintenance inside of an electronic health record. I think that there are a few kind of approaches. What we do locally, what we do here is that we really only have one adult discharge order set for inpatients, and so we have a very, very small number, and we also really force people to use it because if you really wanted to take the effort, you theoretically could discharge somebody without using any order set, but we have a lot of blocks in place to try to force people to use that order set. And since almost everybody is using that same order set, kind of can build around that issue. I think if you have multiple order sets, there are a few potential ways to address that. Obviously, one would be to try to collapse them into a single order set, which I know takes a ton of work and is easier said than done. Another is trying to suggest the right order set. So like in Epic, you have the ability when somebody's discharging to suggest which order set you think they should be using. And you can use similar logic to say, this patient has this diagnosis on their problem list or had a cath admission. And so we really want you to use one of these two order sets, which have the automatic referral built into it. And then there's a third approach, which I think is a fair amount of work up front, but helpful long-term for maintenance, which is to build kind of a single section that can be used that you take, you spend one effort to put it into all of the order sets. And then within that section, you can show automatic referral, you can show kind of anything else that you want to be more dynamic. And then in the future, you just add it to that one section and it automatically goes across all the order sets.
All right, thanks very much. So, and I think that the input from Amy and David should be reinforcing the message that there's not a single way to do automatic referral, and what is going to work well in your situation is probably going to be a little bit different than what's going to work best at Mass General or somewhere else. So we really appreciate Amy and David noting that there are multiple ways of doing some of these things because you're going to need to discuss with your IT department and with the other partners on your team what's going to be the best way that's going to work within your culture and within your workflow processes. So let's move now to this second question category related to diagnostic codes. And one of the questions that just comes up, in the registration today and in other events, is how do we make sure that the patients are assigned the right codes that make them eligible for CR instead of some other codes that don't? Amy, David, how did you work through that issue?
So I guess, so there are kind of two pieces, right? One is the patient record is someone putting the right diagnostic codes on the record, and that we really have no control over, right? I will say historically we have struggled with the accuracy of the proverbial problem list. We know that people don't do a particularly good job of kind of maintaining it and accurately putting information on it. We ended up relying on procedural records as well as diagnosis codes to try and kind of augment that. You can't have the procedure happen without the order in Epic. So in some ways it's a more reliable way of identifying the patients than the problem list, although we also did look at the diagnostic codes. In terms of which are the right diagnostic codes to include in your groupers, so to include in the build, we really relied on the cardiac rehab folks as being kind of the experts in what should be on our list of this buys you a ticket for this process.
All right, thanks very much. And you know, and we're going to talk a little bit more about, you know, education and training. But you know, if you review a number of records and you find that some codes are consistently not used when they should be, then that may be something that you want to work with the people that are doing that on, just to provide them with the education. Because if you don't have the correct codes at the start, probably you're not going to wind up with a correct automatic referral as well. So beyond getting the right codes in there, I think one of the other questions related to diagnostic codes is, you know, for heart failure patients or patients that, you know, weren't in the hospital for a cardiovascular procedure, how do you make sure that you're identifying correctly those patients, in particular because they may have had the heart failure in a prior, you know, hospitalization or in the outpatient setting, as opposed to what they're currently being hospitalized for. So what's your experience with heart failure and programming that into automatic referral?
We currently, like Amy said, we use the problem list for that, and kind of have multiple efforts to try to encourage people to use the problem list correctly, though I'm not sure how successful we are with that. In addition, this isn't actually something that we currently are doing, but we probably should be, and I think would be a good approach, is that we have a registry for heart failure patients, which takes into account, you can be on that registry based on your problem list. You can be on it based on echo results, kind of a bunch of different criteria that could get people on it. And then it's kind of, you know, as an institution, how we define people who have heart failure. And so I think that is another kind of would augment what we currently have, and then similarly, like making sure obviously they're not currently in cardiac rehab, so that we are targeting things correctly.
Yeah, and you're commenting on what you have and what you don't have and still need to put in place. I think, you know, brings out an important message for, you know, everyone that's listening to this, which is you don't necessarily have to have automatic referral perfect in order and absolutely comprehensive in order to start using it and using it to good effect. And conversely, you know, so don't like try to get perfect before you start things. And then conversely, just because you have an automatic referral system in place doesn't mean that there still aren't areas where you're going to want to be continuously improving on it. So David, from your perspective, how many changes have you made to the automatic referral system since you initially rolled it out?
Yeah, I would completely agree with what you're saying. Like, don't let the perfect be the enemy of the good. And in general, I think we try to have that be our philosophy, that try to get something working, and then we monitor pretty closely to see what we're missing. So for cardiac rehab, for example, initially we were trying to include procedures, and we were looking at if you had a cath, if you had an angiogram. But we were including a bunch of people who had an angiogram, but they didn't have any coronary disease. And so then we had to refine it to say people who had an angiogram and had a stent placed or had evidence of coronary disease to, you know, cut down on the misfirings. And so we made a number of changes. The other place beyond the order set that we have this is we have an alert. I think we have a picture of it actually on the next slide, but we have an alert that shows in primary care and cardiology offices that says essentially this, that you know your patient qualifies, place the order, and these are like you were saying, all the different places that people can get cardiac rehab. And this, if you click on any of the buttons at the bottom, people will leave comments about why, either why the alert wasn't appropriate for this patient. We monitor that very closely to make changes in it over time. So I don't know the exact number, but my guess is a lot. And we still are making changes to this and really trying to analyze if this is making a difference at all. Like, is it helping, or is it only helping in a subset of people, and can we restrict it to those?
Yeah, thanks very much. This like what you're seeing on your screen right now is an excellent illustration of trying to make the right thing to do, the easy thing to do. You've got the order, which is the first choice for each of these, as opposed to do not order. And then they can specify which facility they want to direct them to. So a lot of very good design things that went into this. And as you were designing this, David or Amy, did you show it to physicians? Did you test it out? How did you like come up with this structure as opposed to, something that would have been less useful than this is?
I think it helps having a cardiologist as the head of everything, and so we showed it to Amy. But we also we have a number of informaticists and informaticians on the team, and so have looked at it. And we really actually primarily just rely on our. We have a style guide that we use for all of our best practices advisories, all of these alerts in Epic, where we always try to remember why did this alert show, and explaining like why is this relevant for this specific patient, and have relatively standard build around this. I think it's always a good idea to show it to people beforehand to make sure that it's clear, and that the action that we want people to do is straightforward. The other thing that we always do with these type of alerts is that we Epic, you have the ability to build something that never shows to people, but that you can track. And so before we turn on any alert, we put it into that silent mode. And then we look at the charts to say, okay, it would have shown in this for this patient. Is this really the right patient? And doing that, we can catch mistakes before they bother anybody.
Yeah, thanks very much. And some people ask, is it possible to build in the reasons if they're, declining cardiac rehab, the reasons why? And you look at the screen and pretty clearly, that is very possible to do, and an important thing to do. So, Amy, have you used that information? What the reasons are, do you look at that? And if so, what do you do with the results? And how have you used that to improve the process or in your ongoing efforts to promote cardiac rehab to the cardiologists or others?
So I don't think we've really looked at it on this particular alert. It is something that we do in some alerts to see, if there are particular behavioral patterns that we want to try and act on. So the data is definitely available. It isn't something that we've really focused on with this particular one, though.
And do they have to click one of those reasons, or is that optional?
In this alert, it's optional.
Yeah. And again, this goes back to, I think, David's comments early on. You want to set up a system that doesn't irritate people. It makes the right thing to do easier, but it doesn't, force them, and I can see a cardiologist, if this was required, being annoyed because they had some other reason and it's not in the list. And so, they're being forced to check something. But if it's optional, then you don't have to worry about that. So that's all a part of a very good design. And thanks very much for that example. And I want to encourage you, if you have questions, if you're looking at the screen, if it's different, or if you're wondering why they did things the way they did or didn't do them other ways, by all means, put your questions in the chat and we'll be happy to get Amy and David to respond to them. So let's go back to order sets for a bit as we look at our third category of questions. how can we get, there's a lot of questions about, if things need to be signed off on, how you get them signed off on by the right person, as opposed to, as opposed to somebody else. And I see a question from Christine coming in. Is that alert, popping up for clinic visits or during inpatient? So David or Amy, do you want to clarify that before we move on to order sets?
Yeah, I was just going to type it. The alert shows in clinic visits after a patient has been recently discharged, not inpatient. We just use the order set.
All right, thanks. So let's turn to signatures now. How do you get the right person to approve the referral as opposed to somebody else? And sometimes that's complicated with residents and others. So how have you worked through that issue within your systems?
So since we embedded ours in the discharge order set, the discharge order set gets routed to the attending of record, and they essentially sign it as part of a larger package. And so in working with compliance said because they're signing everything about the discharge, including that order set, we will take that as a cosign on the order. There is kind of the CMS issue around advanced practice providers not being able to refer to cardiac rehab unless that has changed recently. So that's why we had that conversation. And that kind of compliance blessing allowed us to not worry about who was placing the actual order set and responding to the order question, but just rely on the fact that we knew that we would send this to the attending of record and they do sign it.
Yeah, and that brings out another critical participant in the team that Amy was talking about at the start, because if you're not setting things up in a way that your billing and compliance departments are comfortable with, then you've got a different set of problems that are really pretty easy to avoid if you're including them from the start. So that's an important insight. Having the right team, it sounds very basic, and sometimes if it takes a while to get people fully engaged, there's a temptation to move ahead on your own, or alternatively get the IT department to move ahead on their own, and neither of those approaches is going to get you where you need to go. So having the right team is really critical. So other order set questions. Sometimes there are different care paths, and can automatic referral be part of a care path that, if you don't have a single, discharge data set?
I'm trying to think. I mean, we don't use some. We don't. Epic does have some different pathways and care paths that you can use that kind of follow along with a patient across multiple encounters. We have not set those up here, but you could. I mean, this could definitely be part of one. Yeah, I don't know if you have anything.
Yeah, I would agree. I mean, so a care path kind of is, BPAs, right? And so you could do this in a care path, or you could have an inpatient BPA for that matter. Those are, in general, harder to kind of make people feel like they're part of the workflow, and it's not something jumping out at them out of the flow that they're in. And so I think you may get kind of more frustration. Although if you are a site that uses care paths heavily, then I think people are probably used to that as being kind of their norm, and it would probably be okay.
All right, thanks. Order sets we've talked about. Now and we've touched on buy-in and getting training to get the physicians to not only refer, but also to promote cardiac rehab. So can you just comment on, as you were implementing automatic referral, did you couple that with any outreach efforts to cardiologists or others to, help them to understand the general value of cardiac rehab, or were they already sold on it? So you were able to just focus on making the referrals easier to happen automatically.
So we really didn't do any training or communication around this. I think, training and communication is always a good thing. So if you can partner a campaign to the build change, that's always great. In this case, I think we felt like it's enough in the flow. They're basically being told this patient appears to qualify. Should you send them? That didn't feel like something that we needed to do a lot of training around. But I think, if you have people who have the time and bandwidth to do it, there would certainly be value to that.
Yeah, and this is another area where, depending on where the cardiologists, where they're at within your facility, if they're already very supportive of cardiac rehab, then probably additional training on that doesn't matter. On the other hand, if they're not, then that may be a more important obstacle. If you turn on your automatic referral system and you see that a large majority of the time people are declining, whether or not you have a reason. If they're just not agreeing to refer, then that may suggest an educational process. So as a follow-up question to that, um, uh, what percentage of the patients that are identified and are in your automatic referral process, what percentage do the cardiologists or others decline to make referrals for at this point? And has that changed at all as you've implemented automatic referral?
David, I don't know if you guys have looked at it recently.
We haven't. I was trying to pull it up right now. It's going to take a little bit.
So I know that anecdotally, when we first turned it on, that the cardiac rehab programs all said, "Wow, this is working." But I don't have quantitative data on how well it's working or how it's changed over time.
Yeah, and I think a general question that some people asked is, so you implemented automatic referral. Does it seem to be actually working? Are you getting more referrals into your system? So could you comment on that slightly broader question?
Yeah, no, so the feedback from the cardiac rehab programs was that it definitely did cause an increase in the referrals that they were seeing. So they felt like it was a successful initiative.
Yeah, thank you. And David, if you find data, just chime in whenever you find it. But pulling up data while you're talking and listening is challenging. So if you can't, that's not a problem either. How do you educate or enroll providers at facilities outside of your network or city or state? That may or may not have been an issue for you at Mass General Brigham. But any thoughts on that for people that do have, potential referral sources that are outside of their network?
So the focus on this was for a patient being seen in an encounter in our instance of Epic. How do we make sure that the person seeing them thinks about referring? And so there really aren't external physicians per se that we're dealing with, because they're by definition one of our Epic users by nature of seeing these referrals. We didn't talk about trying to kind of build this into Epicare Link in some fashion to extend out to external providers. So I can't really speak to that.
Yeah, that's perfectly fine. And I think one of the things that you know, is, you know, that this does point to is there are, you know, a core set of things that you really, you know, want to have for automatic referral. And then there's a wish list of things, you know, in which you might want to expand it over time. And if dealing with the, you know, outpatient referrals or even the heart failure patients, if that's kind of tricky, you know, you might want to start with the core, and if figuring out how to automate, you know, which facility people are referred to, you know, is tricky. You know, you can wait and do that in a second phase if it's going to allow you to get somewhere, you know, get some of the core functionalities a lot sooner than that. So again, you know, starting off with something and getting something going, and then dealing with some of these additional wrinkles is good strategy. There's a couple questions that have come up in the chat. Is the session being recorded? And I believe the answer to that is yes, we record all these sessions, and yes, it will be available to everyone. Before that, though, we had a substantive question about, so in your system, what happens once the physician agrees to the referral? What happens in Epic, and how is the rehab center notified if they are notified? So could you just kind of talk through how that works for you?
Yeah, so each of the MGB rehabs has a schedule order work queue. So a work queue that they had historically been working on their referral orders. You know, and so these go to that referral work queue or schedule order work queue for them to kind of work, if you will. One thing that we did as part of this in talking with the cardiac rehab programs, there was a desire to make sure at MGB that for someone who said, I don't want to go to any of your locations. They're really inconvenient for me. I'm from, you know, Maine and I want to go locally in Maine, that we had a way to make sure that we tried to help them. And so we actually have an order that's, you know, I'm going to go to an external, I want to send them to an external cardiac rehab. And the cardiac rehab said, we want to get that. So one of the cardiac rehabs volunteered to receive those external referrals so that they could call the patient and work with them to say, here are the rehabs that I know in your area. Let me help you find one and get hooked up so that I'm confident that you're actually not going to fall through the cracks. Whether or not you have the bandwidth to do that, you know, is clearly going to vary. I think it was great that we did have a program that had the manpower and the initiative to kind of try and work with patients, even if they weren't coming to one of our rehabs.
Yeah, and I think that also points to, you know, in a way, automatic, you know, referral is never entirely automatic. So, you know, there is or there are definite connections between the automatic referral processes that we're talking about in Take Heart, as well as the care coordination processes. Because, you know, just because you make a referral, even if you make it in an automated way, the follow-up is still work, and it's still time and it's still effort. So it's never entirely automatic, but it is easier and more automated. And then there's a question about from Brian. Thanks very much for your question. Or actually a couple of questions. In Epic, is the work queue the only option to have the notification sent to, or can it be sent in a different way, like an email or an instant message or something? What are the possibilities there, David?
Yeah, and so I don't think that there's a technical limitation from the Epic side about what you can do. I think that in general, Epic is set up for referrals to go to work queues and then those work queues to be worked. And the big advantage of that is that there's a lot more information about what happened. So I've tried calling this patient, you know, 1 time, 2 times, 3 times. I got the voicemail. You can leave notes and there's a clear like audit trail about what has happened. I think, you know, in-basket messaging or other messaging in Epic kind of isn't as much of a closed loop system. And so it's not really what they typically recommend or what we do for most of our referrals.
Yeah, I would agree. I think that, what works well depends on where you're trying to do it and how you're trying to staff it, right? So I have heard of places where they actually have someone, and this would be great if one had the manpower. They have someone who goes to the inpatient while they're still an inpatient to say, you qualify, rah, 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 let's get you plugged in. And so if you're trying to get the referral to that person, first of all, the discharge order set probably isn't going to work because it's probably too far downstream. But for that type of person, you may want to have kind of a different, there's a way in Epic that, I can trigger a page to you when this order happens. So there are kind of other creative things that you can do depending on who needs to know what about the order being dropped, if that makes sense.
Yeah, thanks. And obviously, there are data security issues associated with using emails and instant messages. And that's another reason for making sure that you've got somebody on compliance or the right other departments, legal, just depending on how you're organized, that understands what you're doing and is comfortable with it. Because sometimes it's easier to make people comfortable than it is to make them comfortable once they've gotten uncomfortable because they didn't understand how you were doing something. So a variety of possibilities there, and they all obviously need to be secure. So thanks very much for those questions, and I think uh, um, I think uh, we've covered all the questions in the chat. I think we addressed the one from Brian earlier. I see the question from Brian about what generates the automatic referral. Is it a procedure or a code? Our institution has said that Epic doesn't generate automatic referrals. Instead, the provider has to save cardiac rehab as a favorite. Response to that.
Yeah, so this sounds to me like some confusion on what you're trying to get your Epic team to do. So I think your Epic team is taking this to mean you want me to magically create a referral behind the scenes that no one ever sees and no one has to sign, and it just happens. Which actually you technically could do in Epic, but I think it's very rare that people do that in general, and almost certainly not for this particular instance. So automatic referral in this case is more, I want to build into the workflow a way to let the provider know, I think this patient qualifies. Can't we send them to cardiac rehab? Here's the referral. Can you just sign it, kind of thing. And so it's not so much that you're generating an automatic referral. You're either firing an alert, so that best practice advisory, or you're integrating the order into an order set that you believe the provider is going to be using. Does that make sense?
Yeah, thanks. And then as a follow-up from Wes, have you experienced an impact on wait times for patients as if you succeed with automatic referral and it starts working well? It sounds, Amy and David, like once you implemented it, that increased the number of referrals. So did you have capacity issues with the the cardiac rehab program being able to support all the referrals that they were getting?
I haven't heard anything about capacity issues, even back in the pre-COVID days when people actually wanted to come in person to things.
Yeah, and certainly capacity issues range a lot, across programs and systems, and that may be a really important issue for you to think through. So thanks very much for the question, because if you're absolutely at 100% capacity and you've already got a long wait list, then automatic referral, if you implement it without being prepared for an increase in referrals, you may be, creating one problem as you attempt to solve another. So, making sure that you've thought through how you're going to handle that. And I will point that out that in the 3 care coordination modules within the Take Heart curriculum that are available on the Take Heart website, we do talk about some options for increasing capacity because you may be at 100% capacity, but can you extend the hours? Can you do other extend the days of the week? Can you do other things that would increase your capacity? So thinking through that's why Take Heart involves both care coordination and automatic referral. Because if you just do automatic referral and you don't also enhance your care coordination, then you may wind up with the kinds of problems that Wes is asking about. All right, and then I see a question from David to everyone. We haven't extended to looking at we haven't expanded to looking at notes because of the technical complexity, and we try to encourage people to use the problem list. For those that might not be familiar with the problem list, can you just comment, David or Amy, on or respond to David's comment?
Yeah, and I was trying to respond to Christine's comment, who's asking where in Epic is automatic referral looking for codes to identify appropriate patients in PNs, which I think progress notes, op reports, or meeting diagnosis. And so we currently are really only looking at the hospital problem list for those codes in terms of diagnostic codes. And then, as Amy said, we also look for what procedures were really performed. And so that really gets at the op reports. In terms of progress notes, Epic's ability to kind of read text at this point is not great, and so we really haven't done that, and we just encourage people to code things correctly in a structured way that Epic can see.
Right, and then a question or two from Christine: where in Epic is the automatic referral looking for the codes to the to identify the appropriate patients? Is it, in the PNs or the op reports or the admitting diagnoses or all of those things, or you can change it depending on how your system is set up?
I think, yeah, that's kind of what I was just trying to talk to, but primarily the problem list and the procedures that were done.
Yeah, and again, we'd encourage you, if you start off by focusing on those things, you should review. And if you see that that's missing some, an important number of patients that would be captured with one of those other methods, you may want to consider using some of the others as well. But those are, good places to start. And then I see Lucia's got a question, or Lucia. Does the automatic do the automatic referral established programs also use it for ITP? Responses to that?
Yeah, so we actually do our ITPs in Epic. It's a order-based ITP. It's kind of painful, and as I was leaving Mass General Brigham, they were asking us to redo how we had built the ITP. So I think some other programs use a smart form based approach rather than the way that it was originally built at MGB. I think that smart form approach is honestly probably better. We do most of our cardiac rehab documentation in a third-party system, but the ITP itself is in Epic.
Thanks. And then Christine has a fascinating question about the Cupid module. So, and I'm not going to assume that everyone on this call knows what the Cupid module is, although it sounds like we would love it if we did. Is that module needed to create the most robust and effective automatic referral?
You don't need Cupid for this, no.
All right, so perhaps for Valentine's Day, yes, but automatic referral, not necessarily. Excellent. All right, let's kind of move ahead. This has been, some great questions. Some questions about, how do you do automatic referrals to outside facilities? And I think Amy and David, you've commented on that. You've shown us how you give options to refer to a range of programs in your system, or you have another one to refer elsewhere. Anything else you'd like to add to that question of referrals to outside facilities, since that's important for some facilities.
Not that I can think of.
All right, and David, you had a couple of other example pages that you wanted to perhaps comment on. Can we take a look at this order set page? And could you just tell us what this illustrates, since people, have expressed the desire? Can we actually see what the discharge orders look like? So could you just talk about that if we can go to that slide?
Yeah, so this is the, like I was saying before, we have essentially a single discharge order set for inpatients. And this is one section of the discharge order set. The discharge order set contains all the other things about when people should call the hospital, what their diet should be, wound care instructions, etc. And then one section one section in it is a referral to cardiac rehab. And this section only shows, as we've been talking about, for the appropriate patients, and gives the same list of referral options that we had that we saw in the alert on the previous slide. And then if people don't want to do anything, they can click the bottom patient will not be referred or is not appropriate. And if they expand that, it's kind of similar to that alert where you can specify why the patient isn't appropriate or shouldn't be referred. And then on the next slide is the actual order. So this is when you expand what we had just seen on the previous, clicking on the referral to the Foxborough Cardiac Rehab, the information trying to get at whether it's a new or established patient, and then more information that's useful for the for cardiac rehab and the work queue.
All right, thanks very much. We're getting close to the top of the time. The questions have been coming in, which is fabulous. A last question relating to our last category of reporting. How do you find patients in Epic to see if you're missing some? And what sort of reports do you use to make sure that you're getting all of the referrals that you should be?
So I think part of the question is how we make sure that we're getting all possible patients. I think we very likely are not, because people aren't using the problem list, or they're only documenting things in notes or a number of other ways where we just, we can only work with the data that's available in Epic. But with that caveat, I think there are a number of different ways to find this. Probably the best right now is using Epic's Slicer Dicer tool, which is a pretty fast way to look across your entire population of patients. And using that, there would be a number of different ways to approach it, but you could say, you could filter down to all patients who have a problemless diagnosis in one of the groupers that Amy was talking about, or who has had a procedure, and then you can kind of go from there to see whether or not they've had a referral to cardiac rehab. As Kathy's saying, Slicer Dicer is delayed the calendar day before. And so that's helpful, I think, when you're looking over, what are your trends and looking over a bigger population. If you're trying to find information about all the patients who are currently in the hospital, or that you need kind of up to the minute or real-time information about patients, then using some of the reporting workbench reports. And similarly, those could be set up to look across pretty big sections of the population with the same criteria, what's on their problem list, and what procedures they've had. And most of that can be reused between, if you kind of create that definition in one place, that can be reused between the order set, between the alert, between the report. So you have consistency in the data and see who isn't getting that follow-up order.
All right, thank you very much. We're at the top of the hour. We'd really like you, if you had a chance, to just tell us one useful insight from the conversation today that you're taking away. If you just put that in the chat, that'll give us a sense, give Amy and David a sense for which of their many insights you found the most useful. And then, as a reminder, there is an upcoming module 7 on troubleshooting. You can register for that and listen in on that, even if you're not part of the existing cohort. And then we have recordings for Module 7 on the website that you can listen to at any time at your convenience as well. So all of the all of this session has been recorded, and we'll make available the recording of it to all of you, as well as the slides, so that you can listen to it again. And if other questions come up that you really have about automatic referral, if you're participating in the current cohort, by all means, bring them up in your peer action group, and we can discuss them there. If you're not, you've got a specific question, you can submit it to the Take Heart inbox that you can find on the Take Heart website, and we'll try to help you there as well. And then we just ask for feedback from you as the survey questions come up as you close out. If you could just respond to those, that will give us a sense for how useful the event was and how we can improve them in the future. So I want to thank our panelists, Amy and David, for your incredible insights, for your the progress that you've made, and for your candor about the progress that you still need to make. And that's really what we want to see for all of you is progress towards better supporting your patients, getting more eligible patients referred to your cardiac rehab program or somewhere else, and then getting them into it and successfully out of it to improve their quality of life. That's really the ultimate goal of Take Heart. So thank you, Amy and David, very much for your time. Thank all of you for joining us today, and we hope you have an excellent rest of your afternoon.